morning, everyone. From the Inter-American Development Bank, we welcome you to the webinar, Time for an Upgrade, How Digital Interventions Can Improve Treatment of Non-Communicable Diseases. Thanks for joining us. This webinar is the second webinar in the series, Transforming Health and LAC Through Innovation, jointly organized by the IDB, IDB Lab, and IDB Invest. My name is Jennifer Nelson. I'm a senior digital health specialist here at the IDB, and I'll be accompanying you throughout this webinar. To listen to this conversation in the language of your preference, I invite you to select Spanish, English, or Portuguese on the interpretation icon. Different speakers will be speaking different languages throughout the presentation, and we'll let you know in the chat which language they'll be speaking in. We will also have Q&A functionality at the bottom of the screen available to you so you can post your comments and questions throughout the webinar. By the end of the panel, we will select 2 to 3 of the questions to be asked to the panelists. So let's get started. I don't think it's a surprise that one of the greatest challenges facing the region is how to detect, prevent, and manage chronic and mental health. In this webinar, we aim to answer a very simple question. How can digital interventions contribute to combating these diseases? Let's start by sizing up the challenge. Non-communicable diseases represent a growing burden of the disease burden of the region. The most recent data indicate that 77% of the total disease burden in LAC consists of these types of diseases. To add to this, there are significant gaps in the detection and treatment of these diseases in the region. For example, 35% of hypertension cases are undiagnosed, and between 30 and 40% of diabetes cases are undiagnosed. And even among those that are diagnosed, it's estimated that between 50 and 70% are not controlled. And perhaps the biggest gap, according to data from PAHO, is related to mental health challenges, noting that 70% of depression cases do not receive treatment. Now, NCDs do not only have a health consequence, but also economic ones. For example, it's estimated that between 2011 and 2031, NCDs would cost the global economy $30 trillion. In terms of productivity and years of lost life, this is almost half of the global GDP. On the other hand, these diseases also have a high cost for healthcare systems. For example, diabetes, with nearly 15% of national health budgets being absorbed by this disease. In addition to all this, when we consider that the determinants of health, it's estimated that 90% of health is determined outside of our healthcare facility. That is, factors such as physical, environmental, social circumstances, and individual behaviors carry much more weight. This is even more evident for chronic and mental illnesses. So, we know digital health is part of the solution, but which digital health interventions are the most effective, cost-effective, scalable, and sustainable? To get some of these answers, IDB and IDB Lab worked together to bring together this webinar. Today, we will share both quantitative research and experiences from people doing this work in the field in the public and private sector. To get us started, I'd like to ask Cesar Buenadicha, the head of the Discovery Unit at the IDB Lab, to share a few words from IDB Lab's side. Thank you.
Thank you so much, Jennifer. Good morning, everyone. Welcome to this webinar, very important one around non-communicable diseases and mental health. My name is Cesar Buenadicha. I'm the Chief Discovery Officer of IDB Lab. IDB Lab is the innovation and venture arm of the IDB Group. We work in supporting innovations that can scale through a public or private sector and that can really meet or help to meet the challenges that we have, increasing challenges that we have in the region, in the coming years around many of the topics that Jennifer was describing below. we believe that there is a huge opportunity to some of you to collaborate, to work together, to develop these innovations that use maybe technology and the power of markets and in connection with the needs of governments and other actors to scale social interventions in health that can support aspects like teletherapy, for instance, how much we need, on how many of us have we used teletherapy during the pandemic, and how many of us we use it right now. The opportunities are incredible. Digital mental health apps. This is an increasing area that we are working in IDB Lab. We launched last year a publication around mental health and entrepreneurs, because this is an area that nobody talks about, but some of the most brilliant minds in the region and in the world are suffering from mental health problems as well. And we need to talk about that and to share the experiences and to work in an ecosystem environment that support those people so they can actually help with the problems that we all face. Wearable technologies, we all have the Apple Watch, things like that. Now it's charging. My Apple Watch is charging right now because it's not yet there for many hours of use. But we all have wearables, and wearables are becoming increasingly more accessible for everyone. And we can really prevent and make an early detection of many of those technologies. How we use that data that the wearables are giving us is another question that we have, and we are working with the Social Protection and Health Unit around best practices on the use of data and artificial intelligence. So this is something that we also want to put in the table as part of the critical discussions that we want to have. Artificial intelligence, some of the innovations that you're going to do or you may be thinking about are around artificial intelligence. There is a huge promise, but there is also huge risk of doing and developing artificial intelligence that doesn't meet the standards that we need in order really to support and to protect the most vulnerable populations in the region. So this is a work that we want to do together with the health and social protection sector. We really would like to develop an ecosystem, and a vibrant ecosystem of actors that are willing to explore new ideas and innovations together with the public sector. And we know that the B2G, the business to government model is not sometimes easy, but it's very much needed. So we really need to support collaborations between the entrepreneurship sector, the public sector, and growth of health solutions that can really support the challenges that the region has. Just to give you a couple of ideas, we are working in a mental health startup in Mexico with a mental health called Care that is supporting the training together of caretakers in Mexico and in the region. This is a great initiative that is scaling very fast, and we really would like to see opportunities like that. Another one is Tu Consejería in Guatemala. That is an app that provides mental health online to poor populations in Guatemala and migrants that are crossing to Mexico. So we are very proud of these initiatives, and we are looking forward to identifying new opportunities that can really break barriers of access towards the population. Thank you very much for your attention. I really look forward to this webinar and all the conclusions that you may find.
Thank you so much, Cesar. So now our first speaker is Dr. Pedro Bernal. Pedro is going to be speaking in Spanish. So if you need interpretation, please go ahead and switch now. Pedro Bernal is a health economist in IDB, and he will be discussing the main takeaways from our publication, Time for an Upgrade, using digital interventions to tackle non-communicable diseases. Go ahead, Pedro.
Gracias, Jenny.
Thanks, Jenny. In the face of the context that Jenny and Cesar have presented, the question we'd like to answer in this presentation is how digital interventions can help tackle diseases like diabetes, cardiovascular disease, and depression in the region. As Jenny said, this presentation is based on our recent joint publication with the research division at the IDB. If you wish, you can find the link and QR code down there. Now, how can digital health help tackle these conditions? In several ways. I will mention 4 challenges and 4 examples of digital interventions. One very important challenge in the early detection of diseases like diabetes and hypertension has to do with digital tools that allow non-medical personnel to detect cardiovascular risk and thereby enhance the detection capabilities of the health system. Then there are the limited human resources, a challenge that many countries in the region suffer from. And there are digital interventions that allow the resources to do more with fewer resources by delegating tasks. And we'll be showing some examples of this. Another important factor is reducing risk factors such as overweight, obesity, and little physical activity. There are digital interventions that help empower patients and offer them tools for self-care and for self-management of these risk factors and diseases. Last but not least, these non-communicable diseases are treated by a team that has to be well coordinated to achieve good results. There are digital interventions like electronic records and digital information sharing to help coordinate things. Now, during this presentation, we won't talk about the foundational side of things in digital healthcare like infrastructure, but rather we'll talk about apps that help us deal with the diseases we're dealing with. When we first set to work, we realized that there are a wide variety of digital services and applications. In 2019, there were over 10,000 mental health apps, and faced with this wealth of applications, the question arises as to which ones are effective and which ones may help us tackle the challenges faced by the region. What we do in the publication is quite simple. We start by looking through the literature, trying to understand what interventions or digital applications have proven results in terms of the population's health. Do they manage to reduce the sugar levels in diabetes suffering patients, or in the case of depression, do they have effects? So what we do is systematically review literature and use meta-analysis from 2015 to date. And we detected two interventions which we think hold promise, one for mental health, another one for diabetes, and we perform a cost-benefit analysis in the context of 4 countries in the region. The first example has to do with digital interventions for treating depression. As Jenny noted, the main challenge here is that only 1/3 of depression cases get treatment in the region. And why is this so? Well, in fact, there are many reasons for this. The limited availability of human resources for mental health. On the other hand, only 2% of national budgets go into mental health, and most of this is in the context of psychiatric hospitals. And in our society, stigma also places constraints on the ability of people to seek help. And also, during the pandemic, the prevalence of diseases like depression increased by an estimated 30%, so the challenge became even greater. What mental health interventions have we found that can be effective? One is teletherapy, and the other one is behavioral cognitive therapy. Teletherapy is through video conferencing or the telephone. It's been found to be as effective as in-person therapy for several mental health conditions, including depression. And this is an important result as it reduces access barriers like distance and stigma. On the other hand, we have different digital behavioral cognitive therapy options that can be as effective as in-person options, and which also improve the productivity of healthcare workers. Before moving forward, cognitive behavioral therapy is supported by a wide evidence base. It focuses on developing skills among people to alter unproductive thoughts and modify behavior. It's usually limited in time. You see effects in 10 to 12 weeks, and it's one of the first-line treatment options recommended by WHO. Now, there are different modes of cognitive behavioral therapy. All of them seek to develop these skills to tackle unproductive thoughts among patients. But what does vary is the role of the therapist. For example, in person or telephone treatment, the therapist decides if the treatment is appropriate for the individual, and then an attempt is made to allocate tasks, educate, and in the case of internet-guided therapy, the therapist also needs to decide what is appropriate for the patient. But the educational side is through the internet, through digital means. So the advantage is that when it's in person, for a whole course of treatment, a therapist needs to allocate 6 hours. But when it's internet guided, it's just 2 hours, which greatly increases productivity. And one important difference between these two modes of cognitive behavioral therapy, we see that 85% of patients who start treatment will complete it in person and telephone context, whereas in the case of internet-guided, some 65% complete the treatment. For the cost-benefit analysis, I said we will perform, we work on the basis of a scenario asking what would happen if 2% of psychologists in the country were to treat depression using different modes of cognitive behavioral therapy. We'll take the example of Peru. So we are looking at 70 therapists in Peru who in person over the course of a year could treat 13,000 people. And if we were looking at internet-guided therapy, the same number of therapists could treat over 30,000 patients, so over twice as many. Even though there's less adherence, they obviously spend less time, and the results are very encouraging. Now, what about the cost-benefit analysis? For in-person therapy, we find a cost-benefit ratio of 5:1, so the benefits largely exceed the costs, and we see an increase to 15 million in terms of net present value. In the by telephone mode, there are savings, for example, as regards transport, having to commute or go to where the patient is. And we also have interesting takeaways. First of all cognitive behavioral treatment alternatives offer value to society. Secondly, a health system doesn't necessarily have to decide to offer treatment only in one way. Different modes can be suitable for different situations. For example, telephone can be good for areas that have no access to the internet, and in-person treatment can be set aside for patients who have severe depression cases. Another important thing is that this kind of therapy has been tested and proven in higher income countries, which in Latin America would require some work, including, among other things, regulation. Our second example has to do with digital interventions for diabetes and cardiovascular diseases. In the literature, we find evidence of interventions that offer detection, prevention, and management alternatives for these conditions. I will not dwell on this, but you will find the detail in the publication, and I will share an example relating to an intervention to prevent the onset of diabetes in patients identified as pre-diabetic. In order to prevent the development of diabetes among these patients, you need to do two things: increase physical activity and achieve weight loss. It's easier said than done, as you very well know. Some interventions exist which are designed for in-person approaches, and they have been proven effective. In these interventions, health personnel educate, train, motivate, provide feedback, and follow-up for patients on dieting, physical exercise, and behavioral changes. And the results are very significant. And we find a 58% reduction in the onset of diabetes. The thing is that this intervention requires a lot of time of work by the healthcare workers. And of course, our systems have their constraints. So we have developed or seen the development of alternatives that reduce therapist time digitally. For example, interventions that through text messages help the therapist provide some guidance in 10-15 minutes to the patients, And text messages provide the education and motivation to the patients, and the interventions offer a 5 to 30% reduction in the onset of diabetes. And in between, you have interventions that combine the role of the therapist and the role of digital interventions. The question is, what would happen in terms of cost benefit if the SMS intervention were to be offered to pre-diabetic patients already detected by the health systems? Well, this example relates to El Salvador. What we can see here is that the cost-benefit ratio is also highly favorable, even in different adoption scenarios. What do we learn from this? Personalized messages can be effective for diseases or conditions like pre-diabetes, and also technology helps us reach wide audiences and scale up the contents, and the quality of the contents is obviously vital as well. And risk reduction interventions are very similar to the ones you could use for other conditions and for treating other diseases. So to wrap up the presentation, just a few takeaways. First, digital applications can help tackle non-communicable diseases and mental health. Secondly, there are many gains to be had from the digital delegation of tasks as far as health personnel are concerned. We still need to do quite a bit of research on the LAC context in order to adapt and test these interventions. And of course, there are no simple solutions, no silver bullets. So the health system must look at the different facets when it comes to these issues, but digital solutions can definitely help tackle these matters. Thank you very much.
Thank you so much, Pedro. This presentation provides us with a lot of things to think about, in addition to clear evidence that digital health will be part of these solutions going forward. However, as we all know, it's not as easy as just downloading an app. And here to tell us about what it's like to implement some of these things in practice, we're privileged to have 4 excellent presentations from our region that will be discussing a wide range of interventions related to non-communicable diseases and mental health. Our first speaker is Victor Juarez. He will be speaking in Spanish. And Victor is originally from Guatemala, and for the past 3 years has been working to close the gap in access to mental health among the underserved Hispanic or Mayan populations. Victor, please tell us more. Adelante.
Buenos días a todos y todas. Thank you, Jennifer, por la.
So good morning, everyone, and thank you, Jennifer, for the introduction. I'm Victor Juarez. I founded a social enterprise in Guatemala called Tu Consejería. And just to add a note of information on the context of mental health, in addition to what Pedro said, and regarding Guatemala, based on the statistics, which led to our creation, well, this has had to do with the limited access to mental health. A very small fraction of the budget goes into mental health, and unfortunately, the most vulnerable populations are the ones who probably suffer most from mental health issues. One thing Pedro mentioned, and which I definitely agree with, is that during the pandemic, many apps and digital solutions to deal with mental health were developed, but unfortunately, most of them target people who have resources. So one example we often use is what happens when we are dealing with a young person, a forced returnee, or people who are far away from urban centers, and they realize that mental health is a priority for them. And when they seek options, they're either too far away or too expensive. There are barriers. So that's one of the main reasons for our existence. So our mission from day one, when we started in 2019, has been to offer access to population groups that lack these opportunities. And this we do through a chat for crisis situations. And although we have WhatsApp, for the chat, the idea is to adapt to the target population in terms of the time of availability of services and also to offer immediacy. And with ID Lab support, we are using an AI component through this crisis chat on WhatsApp to provide information from official validated sources to help people find other solutions which are not necessarily in-person interactions. And of course, there's also the issue of the stigma, which Pedro mentioned earlier. Just to give you an idea of what our solution is like, it's not an actual app. We can work as a web-based app, but we found that for our population, downloading an app is quite challenging. The phones they may have available might not have the storage or internet capability to download the app. So we have a web-based chat. Most of our services, in the case of the chat option, are via WhatsApp. And we have been adapting to other solutions like phone calls in Maya languages, in Mapuche, in the case of Guatemala. We try to ensure that this is speedy. And again, now we have the AI component, which will greatly help us build trust. We have already reached out to over 12,000 people over the past 3 to 4 years. Most of the women who've used the services have been women. One of our main audiences has to do with women, female violence survivors, and 41% have survived violence, and many are also forced returnees. In the case of men, the stigma is even greater. And one thing we've seen is that nearly 86% of our users had never had access to a mental health service, which means that we are actually fulfilling our mission and are becoming the first experience these people have of psychological support. And as I said, a large number of the people are violence survivors, and that's another key area of our work. And some of the lessons and next steps, we have learned a lot. It's been a great experience for all of our team. Definitely stigma is one of the greatest barriers, and I think this can apply to all of Latin America. Throughout our history in Latin America and in our countries, we really don't trust people that much. So the stigma is really great. So we have managed to communicate this service in such a way as to get over the stigma and be able to work. Besides, at least in the case of Guatemala, there's very little information on the status of mental health. And through our work with IDB Lab, we'll be doing the first diagnosis, and then we'll be able to tell you where we stand currently as far as mental health is concerned. And the idea is to take advantage of that information. And of course, AI will be super interesting. We're going to use the information also with a view to communicating not just how we're doing, but also where we want to be. And of course, we want to offer support. That's basically our mission. People who are in transit or mobility situations, and also returning migrants, not just in Guatemala, but in the region. And part of my motivation to work with all this has been that we can heal many of our wounds in our societies and region, and this may open up opportunities. So that is an extra concise summary of our work, and I would definitely like to thank IDB Lab for the support, and also thanks for the opportunity to be here. And of course, I'd love to answer any of your questions a little later. Thanks very much, Victor.
Thank you very much for that presentation. Now we are going to switch over to the public sector and take a trip down to Sao Paulo, Brazil. And we are going to hear from Marcelo Tacano, who is the General Coordinator of the Advanced Health Program at Sao Paulo Health Secretary. Please take it away, Marcelo.
Hello. First of all, I would like to thank you everyone to the opportunity to hear direct for São Paulo. and shared our experience with that we are calling the principal revolution of public health system that we are. It was only possible with the support of the IDB team. We have the opportunity to deliver São Paulo the e-Saúde SP like a clinical repository that we are building, recognizing the original efforts to the public health to get digitalized the lab results, the data image, our legacy, and the prompt of hospital care and primary care. They already exist, but it's all, everyone is in the different place. And the first challenge is put all together to build that we call the biggest data lake in the territory of Brazil, even in Latin America. When we are able to put this all together, the sequence is to deliver the population this conquest. Then we build the APP of Saúde SP, and we are able to deliver this conquest for the health professional health and the management. And this clinical repository it's have almost 26 million people of registered, and in the total of very large data settings. Not only the platform is enabled to integrate a large volume of clinical data, test results, and the result of appointments, follow-up of the healthcare tracks, example pregnancy, and the convenience of to other users. Our app is very well recognizing with a very good rating in the app in Apple stores and Google Play, and have almost 3.4 millions of users registers and over 17 millions of access in the platform. We built a pilot of the digital family health strategies. I present to you Livia. Livia is the virtual assistant that we turn possible to fight with the non-communicable disease. I would like to present to you the PANG. The PANG is the glycemic self-monitoring program. We reach almost 130,000 people with these programs, and all integrating the e-Saúde SP. This integration and automation deliver to us the triggers and actions that we have to perform in the process. By the control of non-communicable disease, we present the opportunity not to follow the results of the people, but monitoring how the treatment of the diabetes person is in the daily. And this program it's already offers in the São Paulo city, but the changing the result of this effort is only in the moment of the assistance by itself. With the e-Saúde SP, we are all these information and the result and we keep in the use is shared and used to evaluate the adherence of the treatment and the clinical outcomes. And the difference between the standard moment that we are delivering and the new model of digital family health strategy is the objective. We have the objective to connect to people, and we put all this, the persons together with the digital strategy. We have to know and knowledge the people better. We have to stratify and get the health risk assessment. We provide knowledge for the people. with the right forms to communicate. We have to change behaviors with the change of this content. We have to monitor the people, and we predict and prevent using digital data. We already reached 180,000 people. Then compare the standard model and our new model, we have higher, like 16% higher. And what a good opportunity that we have is not only get this engagement with the people, we have to build this connected like all day, like 24/7 in the continuous forms. We have put the strategies of WhatsApp. That is it's a way in the better form to communicate it. We can interact with the patient directly. We provide the educational materials, and we are able to reverse consultation even for telemedicine or presence, and we deliver the emergent care as well. And making the personality follow up, the people get better evaluation of our results, and we can monitoring all the risks of the diabetes in the most consistent way. We have the opportunity with our clinical data results to monitor all the hemoglobin tests collected in the São Paulo city. And that is one lesson that we learned. In the first of all, we only take the picture of the results with the getting better and the results, structured results. We are able to follow and predicting where is the people of the diabetes, where is the normal results, and could provide a better way to treat these people. Hypertension as well, in following in our health track, and we are able to open a door of by digital that it's not even possible in the past. Thank you.
Thank you so much, Marcelo, for your excellent presentation. Very exciting to see as well these innovations in the public sector. Our next presenter is Dr. Mario Sanchez, who's an IDB lead specialist in social protection and health. And he will be discussing an experience with the government of Uruguay. So go ahead, Mario, take us away. Thank you.
Saludos a todos y todas.
Hello, everyone. My name is Mario Sanchez. I am a senior specialist for the IDB based in Argentina. It's a pleasure for me to share with you a project that we carried out with the government of Uruguay, which I believe helps us to understand how digital intervention can present an opportunity to improve and make health more practical in terms of its delivery. If we could please share if you would allow me to share my screen a moment. As you know, cervical cancer is one of the most common kinds of cancer in Uruguay. Every 3 days, a woman dies of cervical cancer, and it is very frustrating for us to know that a high percentage of these deaths could be avoided if women had been able to get pap smears and other relevant exams at the right moment in Uruguay. Now, why is this a good opportunity, or why is this a timely initiative? Well, because only 57% of women in Uruguay are getting these pap smears in the appropriate time frame. And we're looking specifically at women who use the publicly delivered methods of treatment. Women have come to different health centers, and what we see that access to the center itself is not the issue. So why is it that only 57% of women are getting these tests done? Well, it could be that there's a lack of information available. Users are unaware of the benefits, they don't know what the risks related are, and that's why they're not taking this test, or they're not getting this test done. Another matter could be the cost factor. They don't have the funds to cover the test. And so that may represent a barrier to effective access to services. But it seems that it wasn't for either of those reasons. So we carried out a quantitative study with a representative sample of patients in Uruguay that use public services in the area. We've found that 80% of the women know that they need to get these tests done regularly. 98% of them are familiar with the test. 73% know that they don't have to pay at all for the test. No woman has to pay out of pocket to get the pap smear. And 92% are aware that they can take the day off of work to get the test done. So it doesn't seem like it's a matter of awareness or cost, or at least the answer isn't that simple. Behavioral science shows us that in order to bring a patient in, it's a lot more complex a process. And there are behavioral bottlenecks that cause people to act irrationally. So maybe we put something off that's really important, even though we should get it done. The second thing, is if we look at the realities that these patients might face, something that we see across most Latin American countries is, well, and also especially where you have this kind of public service, in order to get this test done, you need a lot more time investment involved. And so in Uruguay, women need to show up to the health center to request an appointment. They have to get an appointment when one is available, not when it's convenient for them. And then they don't just have to go once to the health center, they then have to return a second time to get the actual test done. With that in mind, we wanted to create a study to test four different alternatives. First off, we would send patients a text message talking about why it's so important and beneficial to get this test done. It helps them to prevent cervical cancer if they test in early stages or early on. Second, there was a digital calendar that kind of was a sort of interface that allowed people to access the platform and use it in, I guess you could call them shifts, sort of. And if you would click on the calendar, you could look at what health center you wanted to head to. You could see what appointments were available, and automatically you could make that appointment. The third alternative was one where we would alert people to the dangers of not getting the pap smear. And finally, we combined the risk-related messages with a digital calendar. So I would like to invite you to give this some thought. If you think that this kind of intervention as a whole might be effective, let us know. Or if not, tell us what you think might work best out of the four alternatives that we tried. And as you're thinking about that, I want to tell you a little bit about the characteristics of Uruguay that make this study that we created so difficult to implement in many other Latin American or Caribbean nations. You might not be able to implement it in many countries at the moment, but this does invite us to take a glance at what kind of digital development might be on the horizon. Now, all women that were part of this did have a digital platform that they had access to and a profile made. So we had the ability to give them the information related to their appointment, and they were able to update that information as they got their tests. So we have updated information on 80% of our participants. This is because Uruguay is one of the most digitally advanced countries in Latin America, especially in health. They were able to develop this way over the course of many years as the result of an initiative, and these are the results. So this was a study where we chose 46,700 users of the metropolitan network known as ACE over the course of a series of months. We were able to randomly assign women to 4 different treatment groups, which I had mentioned previously, those alternatives. And there was a control group that didn't receive any of these or weren't part of any of those alternatives. And they simply were exposed to the traditional methods, ad campaigns, whatnot, etc. And so just to talk about how we were able to customize these services, we sent the messages with the patient's or the user's name included in the message, sort of to make the patient feel that she was being invited personally to come to the health center and get the test done. We tried sending messages 3 times a week, and if the patient carried out the test, whether that were in person or they were able to make the appointment digitally, they received another message 24 hours before the appointment itself. The reason why it's important to take this into account is that we didn't want to bombard people with messaging. So that's why we kept it at 3 messages per week for the course of 4 months. So what would a positive result be? Usually studies like these that have low costs, if you're able to increase indicators by 1 or 2 percentage points within a control group, you can consider that a success. The results I'm going to try and show you here concerning the whole of the interventions that we carried out, the different methods that we implemented. As we can see in the graph on the left, the control group throughout the 4 months of intervention displayed 2.7% of patients going to get the test done. But 6% of the women that did benefit from some of those alternatives I mentioned went and made appointments. Now, that doesn't necessarily mean that all of the people who made appointments went to get the test done. Within the control group, that was about 2% of them over the course of the 4 months. They made the appointment and they got the test done. But that number doubled with the alternatives that we were implementing. So now let's look at what intervention method we found to be the most effective. Now, this isn't that simple. When you compare these numbers with the control group, as we look at the interventions, looking at the messages that explained what the benefits of getting the test were, plus access to the digital calendar, typically the number of women who made appointments, it was a little bit less than in the group of those who received risk-related alerts. So when we look at that compared to women who only had access to a digital calendar, there was a slight difference. So it's not just a matter of engaging with patients. We did need to include an improvement in access to appointment making services. We saw that the combination of both would lead to greater interest and follow-up. Now, again, like I said, not every woman who made an appointment went to that appointment, but we saw this trend where the benefits messages plus digital calendar access tripled results. But the difference was much less with the risk-related messages. And so we were surprised by that because what we've seen in other countries with similar interventions is that what worked best was simply to present the risks instead of the benefits. At least in Uruguay, apparently they were not as responsive to that. They preferred looking at the benefits better. And also we see that text messages worked really well for spreading that kind of information, but they were much more effective if this was combined with the digital agenda. And so this is highly cost effective. The only thing that we had to finance was the development of the digital agenda or the digital calendar, which did require quite a bit of resources and investment. But all of the alternatives here, one might consider to be highly cost effective. And I think that in this case, what we found was that using the positive messages plus access to the agenda or the calendar was the most effective. So thank you again so much from our base here in Uruguay for allowing us to implement this project. As I said, this sort of embodies the possibility or the potential that digital interventions have when it comes to providing better, more personalized service or care. It's unfortunate that I wasn't able to be with you guys physically, but I'm happy to answer any question that a colleague might have and offer more information on the study that was carried out. Thank you so much.
No, thanks so much to Mario for that great presentation. To close our section on country experiences, we're going to travel back to Brazil. And here we're going to hear from Dr. Marcia Escazufca, who will be as a researcher at the Institute of Psychiatry of the University of Sao Paulo, Brazil. And she will be talking about Vida Viva. And without further ado, I'd like to pass it over to Dr. Marcia. Thank you so much.
Can you see my screen?
Yes.
Yes. So, o que eu vou apresentar hoje, né,
So what I will present today are the results of an intervention, social intervention for the elderly population, for population with depression in primary care in Brazil. This social intervention is digital and also within the realms of self-management or self-help. So how much do we understand about depression? Much was already said today. And the prevalence of depression is very high among adults. In the studies that we have developed, we have found approximately 30% of a prevalence of depression. Depression is normally associated to a greater mortality rate, worse quality of life. It will impact people's normal life functioning. It has an enormous impact for caregivers, and it's also associated to other comorbidities. Therefore, it does represent a very high cost for any kind of health system in Brazil, and I guess in most part of low and middle income countries, there is an important gap, a lack of healthcare for depression, not only for the elderly, but for the whole of the population, but specifically for the elderly population. The health system is not prepared to meet the demands of the aging population. Not only that, mental health is not well integrated in primary care in Brazil and also in other countries from Latin America and the Caribbean. The World Health Organization recommends that the treatment of depression should be started in primary care setting and go stepping up until you reach a specialized service environment. This network will show a study by Batista and collaborated. It was a recent study done in Brazil about morbidities from NCDs of this network of morbidities, of NCD morbidities, and how they are interrelated. And this was done with the elderly population in Brazil. the result of this study is quite interesting, showing that depression is possibly the greatest morbidity with the greatest impact in this morbidity and comorbidity network of NCDs. And depression is the most effective target for interventions for the elderly population in Brazil with multi-comorbidities. So this would not only show the importance of developing cost-effective treatment for depression, but how depression can impact budgets in countries. So we prepared two different studies, not only myself, but my whole team. One was called Proactive, and the second one was Viva Vida. These are all clinical trials with the elderly population with depression. Both studies took place in Guarulhos. This is the second largest city in the state of São Paulo. It is a relatively rich city, but part of the population is very poor, as you can see here by this picture. This study, or these two studies, Proactive and Viva Vida, were designed and adapted for primary care systems in the Brazilian public health system, SUS, where most of the elderly population has access. Most of these elderly population do not have access to other health services. It's a bit different from what we've heard before, but in our studies, we have seen that approximately 16% of the elderly population included in our study did receive some type of treatment for depression. And I would like to make one comment here because people do not know that they have depression. Sometimes they're not diagnosed. So it's not just a matter of treatment, it has to be identified. And so maybe this is a bit different from other studies where you have higher rates of treatment for depression, even though they're still very low. So Proactive is a psychosocial intervention. It is a collaborative program. It was done with 715 elderly population. It takes 17 weeks, and it was fully designed to be undertaken within the primary health care setting and family health setting, where the agents were trained in order to do the in-house treatment. This is a collaborative, not only with health agents, but also the rest of the team from the family health system. And in our program, in the Proactive program, the idea is that the person will start with a first service provided by trained health agents. If necessary, they will follow in the program and they will go to the health unit. They will be the family doctor. And if necessary, it will be scaled up and this person will be referred to a specialized care. This study was not 100% digital, but we had some kind of a technical support. We used tablets. The community agents used tablets with different resources used during the first assessment, including videos that were shown to the elderly population. So Viva Vida, the second program, was developed based on the psychosocial intervention. So this is for the adult older population with a depression, and it's 100% self-help. So this is an intervention that does not have the participation of health professionals or agents. This happened through the submission of WhatsApp messages, and this was very interesting to me when we heard of my previous colleague from Uruguay talking about WhatsApp. So this is a 6-week program where the intervention group will receive 48 WhatsApp messages. These messages were submitted 4 days a week, one in the morning and one in the afternoon. These are audio or image messages. These are short messages. And the message is also submitted with the name of the person who will receive that message. And this is very personalized, and people would like that. I would like that myself. So we also included 603 older adults with depression, and half received the intervention and half was the control group with only one message, WhatsApp message. Another important part of this program is that the program submitted messages, but people since the very beginning knew that we would not answer questions. They were aware that they were able to send messages, but we would not be able to answer all these messages because this program is designed to meet different people. It would be impossible to answer all the messages.
They also received messages from the very beginning of the program, informing them that if they needed more help, they should reach the service program to talk about their problems. So what do these messages look like? Ana and Leo, two actors that interact with the population in the messages. They will open each and every message. They will share something. They will also read letters from presumed adults that are enrolled in the program, that are registered. These messages do storytelling, they use storytelling, and through storytelling, they talk about symptoms of depression, the behavioral activation techniques, how to prevent relapse. These are techniques that are not only effective to treat depression, that have been adapted towards this target audience, this population. Our target population is very poor. They cannot read well. They struggle when it comes to reading and writing. And for this reason, we also resorted to voice messages. As mentioned earlier, we do not share videos with them because their smartphones do not have the capacity to support videos. This is a message cover, and this is what they usually receive. They receive this message early in the morning and this one in the afternoon, sharing, well, the key takeaway here refers back to the morning message. In this particular case, one lady is going to share what happened to her recently. She woke up feeling down, feeling upset, and she thought to herself, well, I should really get out of bed and do something for myself. And she had already been enrolled in the program and registered. So she went outside to her garden and she would share with listeners, once I started going out, stepping out into the garden, I began to feel better. So these are motivational messages, encouraging messages. So meaning that she realized that whenever she does something that she likes, that she relates to, that really changes her mood. And this is the behavioral activation technique. And she concludes with the following message. And if it works for me, it will work for you too. Try it. So what have we learned with Viva Vida so far? Most important thing in Brazil and in many other regions in our country, mental health care is not based on evidence. Well, when it comes to psychosocial psychotherapy services, we do not have a lot of evidence. And what to say about apps that can be used as the ones we are sharing today. And these solutions are effective, have been effective so far. These are practical clinical trials, actual trials that have been carried out for primary care. At Viva Vida, we look at the recovery of depression at 3 months once they actually register in the study. And 42.4% of the individuals in the intervention group no longer had depression at 3 months, whereas 32.3% in the control group no longer had depression symptoms. These numbers seem to be very close. However, if we think that these are low cost and simple design studies that can really be stepped up to reach a wider number of people, it's very important. So what are the takeaways, the lessons learned? That the digital psychosocial intervention is effective and sustainable. And as far as engagement, which is an actual issue when it comes to digital interventions, in our intervention, 76% of the elderly individuals opened 36 out of the 48 messages that were sent via WhatsApp to them. It's interesting to note that this is a measure we use for every 6 weeks, for a 6-week period, week over week, and this number does not vary throughout the 6 weeks of the program, which is really quite an achievement because interventions normally start out with high engagement levels, which go down over time. 66% of the elderly individuals enjoyed the program, and most of them would recommend the program to other individuals. We learned that Viva Vida is feasible and has wide acceptance and is also sustainable. What are the next steps? We would like to integrate both programs, Viva Vida and Proactive, in an evidence-based, stepped care program to treat other adults. Those in more need will receive more support. Viva Vida would be the first step of this process. It would be shared with a very large number of individuals. If they do not achieve results rapidly, they could receive home visits, home care, and so on and so forth. It is an integrated program that consists of different steps. And as a reference, Guarulhos is the second largest city in the state of São Paulo, as I mentioned earlier. And it is hard to find psychiatrists in Guarulhos. It's really close to São Paulo, just across the street of São Paulo in a certain area. And at times you will only find 1 or 2 psychiatrists in the public health network. We therefore do need more incentives, a larger number of specialists working in these programs. And the next step would consist of receiving support from government, from the IDB to step up this program, to take it to more regions in Brazil with the necessary adjustments. Thank you very much for your attention, for the IDB, for the invitation. And these studies, these trials are carried out by a team and not by one individual alone, and also through the support of the Secretariat of Health of Guarulhos and of course the IDB. Thank you very much.
This concludes our country section of their webinar, and I'm very excited because now we'll be introducing Dr. Silvina Luciani from the Pan American Health Organization, who's the Unit Chief of Non-Communicable Diseases, Violence and Injury Prevention. And PAHO's been a huge ally for us in digital health for the past 5 years and going forward in many other areas. And here, Dr. Luciani is going to talk to us a little bit about her thoughts and takeaways from what do we do with everything that we heard today. Thank you so much. Go ahead, take it away.
Thank you. Thank you so much, Jennifer. And thank you to you and all the colleagues at IDB for convening us and calling attention to the fact that it really is time for an upgrade to really accelerate the use of digital interventions to tackle non-communicable diseases, which I think we can all agree in the public health community is the greatest public health challenge of our time. I'd also like to just thank all of the speakers for these wonderful, very engaging and innovative experiences that you've shared with us today. So Jennifer asked me to share some of my reflections and key takeaways from what we've heard today in the country panel. But first, I'd like to start by acknowledging this tremendous partnership that exists between the Pan American Health Organization and with the Inter-American Development Bank on digital health. We're now celebrating 6 years of collaboration together, that is working with governments across sectors to really strengthen health information systems and bring forth that digital transformation of the health sector. And this collaboration between PAHO and BID has led to a regional plan of action on strengthening health information systems, has led to a regional roadmap for digital transformation of the health sector, and a new policy on using artificial intelligence in public health. And these frameworks are really important, we believe, in helping to change those policies and practices and really bring about the changes in healthcare and digitalization that we need. And our collaboration has really resulted in many countries updating infrastructure, updating governance and policies for things like telemedicine or electronic health records. And this webinar is just another example of the great collaboration that we have between these two agencies. So just to highlight a few of the things I think we learned from today's country panels across the experiences in Brazil, in Uruguay, in Guatemala. You know, these are different countries, different contexts, different populations, different health systems, but all of these experiences showed us the possibility of harnessing that power of technology to really transform the way healthcare is delivered, making it much more accessible to people who need it, making it more patient-centered, making it more efficient and cost-effective, right? It also demonstrates that the digital health investments that governments and civil society and academia are currently making today to really have an impact and address the growing burden of non-communicable diseases. And I think some of the common messages that I heard throughout the series of the presentations is that, you know, digital health can really increase that communication between providers and clients to really help improve the quality of care and to reach those people who need continuous care, such as those suffering from depression or anxiety or other mental health conditions, or who have hypertension and diabetes and need that continuous access and monitoring. But it also increases the coverage and access. So I think we saw in many of the presentations, the additional number of people that are able to be reached by using digital technologies through enhanced service delivery and as alternatives to those face-to-face consultations, especially in rural or remote areas where access to healthcare may be limited. And we saw these excellent examples from the three countries, the four examples from three countries, but we know many more similar examples exist throughout Latin America and the Caribbean. We have experiences from Mexico on how they're using Salud Móvil to address diabetes and improve diabetes control. We know that in Costa Rica, the government is doing a major transformation of their health system to bring in telehealth services, and in Jamaica with the digitalization of their health services as well. So, you know, we have a lot of examples in the region, and we know that digital health is not new, right? It's been now, if you can believe it, almost 20 years since the World Health Assembly adopted a global strategy for e-health in 2005, and then it was renewed again in 2017 with a new global strategy on mHealth, calling for the increased use of ICTs, information communication technologies, to address the public health needs. But the world has changed a great deal since these global mandates were adopted. And as we know, the COVID pandemic really catapulted the use of digital health solutions, especially to ensure service continuity when all of the health clinics were disrupted and access to care was disrupted, and we had mandates for social distancing. So this kind of explosion of digital solutions for NCDs and other health issues has really helped us to really expand its use. And in the NCD community, we're really embracing the digital health solutions because, as Jennifer mentioned in her opening remarks, NCDs are woefully underdiagnosed and undertreated, and of course need that continuous care and self-management support to ensure good quality of care and good outcomes. And of course, in mental health, we have a crisis of mental health and many people that have gaps in care, gaps in diagnosis and treatment. So these digital tools can really help facilitate reducing those gaps in access to care and improving the quality of care. Teleconsultations, as we heard in all the examples, are really a great way to increase and expand access and to really create a more patient-centered model of care. So just a few takeaway messages from the country presentations. I'd like to start by the first message that I think we can all agree on is that digital health solutions offer enormous benefits for all, for people who are affected by NCDs and mental health, by the providers who are providing care to those affected by NCDs and mental health, and perhaps most importantly, around the governments and health spending to reduce some of the costs. And for people with NCDs, it's really providing that sense of greater autonomy, that self-care, by allowing them to have access to data, information, text messages through apps, having the convenience of telehealth as an alternative to in-country or in-clinic consultations. And for providers, of course, it improves communication and efficiency in caring for people. And with governments, what we've seen, I think, in all of the examples is that it really helps work towards universal health coverage and increasing access and reducing some of those barriers to care. And I think one of the examples also showed that there's some cost savings, right, because of the cost effectiveness of digital health solutions. My second takeaway message is around the moment that we're living in now, 2024. It's a really critical time to advance the implementation of digital technologies for NCDs, because many of the countries are investing heavily in health service strengthening and health recovery from COVID. And along with the technical advances that we have in technologies, the rapidly increased number of apps. I think we saw in one of the presentations over 100 apps to choose from for just mental health. And if we add the NCD apps in there, many, many more. So there's just this explosion of technologies. Many, many public-private partnerships already exist. Many more can be had in terms of really having this momentous opportunity to scale up implementation of digital health solutions for NCDs. And this applies for the whole continuum of care for NCDs. So for example, with prevention, having more readily available technologies to have people assess their own risks, for example, in the next 10 years of suffering heart attack or stroke based on their weight, based on their lifestyle habits, on their eating patterns, on their hypertension, or monitoring their blood pressures, right? So using apps as a way for self-care, for diagnosis and follow-up care, having teleconsultations and patient portals and reminding people to have their follow-up appointments. And digital technologies can also be used, again, for the public health management side of things, for example, monitoring the availability of medicines and technologies and preventing stockouts and being able to ensure that there's enhanced treatment. And of course, I can't not mention AI. AI, I think, is the greatest frontier, and there's infinite possibilities and potentials on using AI to improve health. In fact, WHO just launched a new AI resource called SARA, Smart AI Resource Assistant for Health. And this is something available 24/7 in 8 official languages of WHO. And it's intended to provide health messages and to create that self-care and self-management support, especially for people living with NCDs. The third message I think I took away from all of these is that, you know, while we're all excited about digital health solutions, we do have to be mindful and aware of some of the limitations and help address some of those. And so the success of adoption will really rely on meeting people's needs and changing the practices in healthcare delivery. And this includes things like increasing digital literacy among people, among providers, making sure that there's equitable access to technologies and not having technological advances increase those inequities in healthcare. And really helping to enhance the infrastructure that's needed to support those digital health tools. It also means addressing some of the skeptical people who feel that face-to-face healthcare is the only and best way to provide healthcare. And so offering some alternative measures. And also, I think in the presentation from Brazil, we heard the motivation tends to lag as time goes on. While people get really excited initially to uptake and use digital technologies for healthcare, as time goes on, the motivation lags. So what are some of the strategies to keep that motivation, keep people engaged? And then lastly, of course, the issues around the ethical issues and data privacy that often come up and the need to address some of those concerns. And for NCD specifically, some of the concerns around older populations, people with multimorbidities, and so needing some NCD specific strategies also are important. So I just want to conclude my remarks by offering perhaps 3 recommendations for what we as a global public health community can do in Latin America and the Caribbean to really accelerate the uptake of digital health solutions, particularly to improve the prevention and control of NCDs and mental health. So the first recommendation I'd like to make is that we take a principle-based approach to digital transformation of the health system, recognizing that this is really going to require some cultural changes in the health community and in the way health services are delivered and in the population in general. And at PAHO, we've developed sort of 8 guiding principles on digital transformation. And so we would encourage you to visit the PAHO webpage, download the document on the 8 principles, but it basically involves promoting universal connectivity and inclusive digital health, again, to make sure that we're not exacerbating any inequities in access to healthcare through the application of digital health solutions, promoting interoperability so that there is data shared across domains, and of course, information security to protect people's privacy and confidentiality, among other principles. So taking that principle-based approach. Secondly, the recommendation I'd like to leave us with is to really focus on the primary care settings, recognizing that NCDs are the greatest proportion of health needs in any community, and this is the best place to improve how people with NCDs are diagnosed, treated, to provide that continuous care, and meeting the range of needs of people with NCDs, and considering to include them in the development and the design of the digital solutions that'll be developed to enhance the engagement with the population and the community. So that primary healthcare perspective. And then thirdly, and I think we saw this in all of the country presentations, is the importance of documenting, researching and documenting the impact that these digital solutions are having in improved care. So the call for more large-scale evaluations on all domains of clinical improvements, behavioral changes, as well as service delivery efficiencies. So research and documentation. So I look forward to continuing our collaboration with IDB and with all of you in this path towards digital transformation of our healthcare system and prioritizing those living with NCDs and mental health. So thank you again, and back to you, Jennifer.
Thank you so much. Excellent summary, and not easy to do given the variety of an expertise that we heard of today. So thank you so much. So just to finish this up today, I'm going to pass the floor to Andres Rubio from the IDB lab. We had some excellent questions for the speakers, and he'll take as many as we can until we're done today. So after you, Andres.
So thank you very much. We have here a few questions for the panelists. So for the time we don't have a lot of time, so I'm going to start asking the 4 questions that we have right now. And if any one of the panelists want to answer, please answer to the questions. So the first one is how the integration of open banking and innovative financial models could leverage even further the impact of digital mental health, and what key learnings should we advocate with local governments, especially for Brazil in the presidency of the G20. So Marcia, Marcelo, Victor, Pedro.
I didn't understand the question.
So this is how the integration of open banking and innovative financial models could leverage even further the impact of a digital mental health. And what are the key learnings that for this process we should advocate with local governments?
I don't know how to answer this question, but
Marcelo?
I think the open banking is so easy to do. Probably we can do digital mental health as well. I don't know if I answered. Marcelo, maybe you can say something else.
Yeah, Marcelo and Pablo, you.
Yes, I think the most relevant thing that the question brings to us is the model of the open banking and the organization. That the principal challenge is how to get every person like NPI, Master PT Index. The model banking allows to us to identify and get all the information of these people together. I think that is the aim that we have to looking for, not for using the bank model for the health data model. When we can able to put all the informations together, we can reach impact not even only in digital mental health, but in all the no transmissible disease.
So thank you very much, Marcelo. Pablo, you want to add something? You have raised your hand.
Sí, buenas tardes o buenos días a todos. Básicamente creo que va en el mismo sentido.
Yes, first of all, I think I will echo what was just said. What we're trying to do is introduce new innovation methods and opportunities for co-creation in this context. It's something that we've been learning about in the sector, trying to get familiar with multiple processes that could be implemented. And when we talk about this specifically, we have to see it in a participatory model. All participants should contribute through active participation in an innovative process so that we can effectively generate or produce the tools that are needed to address different challenges as they arise. Thank you.
Thank you very much, Marcelo and Pablo. So next question that we have for Marcia. What is the thing that most surprised you during the implementation of the process?
Sorry, what is the thing that?
What is the thing that most surprised you during the implementation?
Several things. Actually, when we started the Viva Vida clinical trial, we were not sure how acceptable it would be to send WhatsApp messages to this population, if they would like it, if they would follow the program. About the effectiveness, we didn't have any idea. So we did some preparatory studies, some pilot studies, and we had a group of people helping to prepare the messages. And for me, I thought was very easy, just send WhatsApp messages. No, I had an IT group for sending the messages. We sent thousands of messages. So it was very surprising for us, the very good response, and we're doing a qualitative study that we know more about it, and they want more and more. They are not happy the program had only 6 weeks. They would love to continue receiving booster sessions. And if possible, it would be very interesting to continue doing other things. Maybe if the person also has hypertension, can start receiving things about hypertension. It could be scaled up easily. This program was a good surprise for us.
Thank you very much, Marcia. I have another question here. Let me check. Yeah. So as for Victor, as AI is getting more and more attention, how do you see it affecting your work in this area?
Well, actually, I think that AI is giving us a great opportunity to reach more people, which was something, and originally one of our biggest challenges was how we can, in a way, massify or make it more or accessible the mental health information and the reach to more and more people, even the ones that are closer to the base of the pyramid. So I think that AI is giving us the opportunity to do that, not only by potentially giving them the access to professional support that is in person or with persons, but also in a way that we can give information to a big amount of people that doesn't usually have access to the internet immediately, or that doesn't have the type of phone that is needed immediately. So through, at least in our case, using WhatsApp with this component of AI that we are developing will give us the opportunity to do that exactly, to massify the access to information on mental health, particularly at least here in Guatemala. So I see it as a big opportunity for us.
Okay, thank you very much, Victor. Because of the time, we have a lot of questions here. We're trying to answer everyone by the chat, but thank you. We go back to Jennifer.
Thank you so much, Andres. It's wonderful working with BidLab in terms of how to scale up these innovations across the region. So with that, actually, we're out of time. So we want to thank all of you for connecting. We hope to see you in our next webinar of our series called Transforming Health and Lack Through Innovation, jointly organized by IDB, IDB Lab, and IDB Invest. Our next topic will be to focus on open innovation in the health sector. So please stay tuned to our different social media platforms. Please then, if you could help us, speaking of data, we need some from you. So if you could please help us by completing the evaluation that's being shared on the screen, it helps us to improve and make sure we're bringing you relative content going forward. Thank you so much and have a wonderful day, and congratulations again to all our fantastic presenters. Bye-bye.